Samuel. The title is Integrative Approach in ABG Interpretation, and he's from Sri Sathya Sai Medical College and Research Institute, Chennai.
Good morning to everyone. First of all, I thank the organizing committee for inviting me and giving me an opportunity to present my research findings. I am Dr. Rajini Samuel, Professor of Biochemistry, Sri Sathya Sai Medical College and Research Institute, Chennai, India. My research topic is 7 steps integrative approach in ABG interpretation using novel acid-base balance theory. So no conflict of interest. So ABG, as all of you know, is an important, it plays an immense role in ICU. Various approaches are there. The commonly used approaches are physical approach, physiological approach using bicarbonate, PCO2, carbonic acid approach, and base XX approach using standard base XX, and physico-chemical approach by Fencl-Stewart. So Stewart's approach is used to identify the causative mechanism of acid-base disturbances. And I have proposed a novel acid-base balance theory and a newer approach in ABG interpretation, and also I have formulated a newer equation to understand and identify the hidden and mixed acid-base disturbances. So aim and objectives: to develop a novel ABG interpretation method using changes in pH, total, respiratory and non-respiratory change in pH, to construct a novel 4-quadrant graphical tool for ABG interpretation, to apply a newer equation to understand and identify the hidden and mixed acid-base disturbances, and to create a 7-step approach for ABG interpretation, integrating all these approaches. So modified Anderson equation, H plus is equal to 24 into PCO divided by bicarbonate. This is used to calculate the hydrogen concentration. In the same equation, in the place of bicarbonate, if you substitute standard bicarbonate, and in the place of PCO2, if I substitute 40, you'll be getting the non-respiratory hydrogen and concentration. So non-respiratory hydrogen concentration is equal to 24 into 40 divided by standard bicarbonate. So NRH plus is equal to 960 divided by standard bicarbonate. And these are developed by myself. And standard bicarbonate is the bicarbonate concentration at PCO2 of 40. So that's why I have substituted in the place of PCO2, I have substituted 40. And pH is equal to 9 minus log of H plus. So similarly, NRPH, the non-respiratory pH is equal to 9 minus log of NRH plus. And I have shown the graphical relation between the standard bicarbonate and NRH plus. They are inversely related. And standard bicarbonate and NRPH, they are directly related. So if I subtract the pH and the NRPH, I'll be getting pH minus NRPH. So it denotes the respiratory change in pH, the delta RPH. So this is equal to 1.6 plus log of bicarbonate divided by standard bicarbonate divided by PCO2. So in the graph I have shown the relation between PCO2 and the delta RPH. So at PCO2 of 40, the delta RPH value is 0, because if you substitute in the equation, you'll be getting 0. And PCO2, as the PCO2 increases, the value is negative, and as the PCO2 decreases, the value is positive. So based on this, I have postulated a novel acid-base balance theory. The sum total changes in the hydrogen concentration in the blood includes both the changes due to respiratory and non-respiratory components. So delta H plus is equal to delta RH plus plus delta NRH plus. And net changes in total or actual pH is due to changes in respiratory and non-respiratory component affecting the pH. So delta pH is equal to delta RPH plus delta NRPH. And these are already published in my previous research articles. So this delta pH is the total change in pH, pH minus 7.4, and delta RPH denotes the changes in respiratory component, and delta NRPH denotes changes in metabolic, non-respiratory component. I have shown some examples. The pH is 7.31. The pH is 7.31. The total change is pH minus 7.4. So we're getting minus 0.09. And this is the delta RPH and the delta pH. So if this change is due to sum of the delta RPH and delta NRPH. and pH is 7.4, the change is 0. So both delta RPH and delta NRPH will be equal in magnitude and opposite direction. This is the negative and this is positive. So I've shown the relation between the NRH plus and the already well-known standard base excess. NRH plus and standard base excess are inverse related. NRH plus is higher, standard base excess will be lower. And I've shown the relation between standard base excess and NRPH minus 144. That is the delta NRPH. Both are directly related. So if you see in this graph, the standard base excess is taken the x-axis positive, and the delta NRPH is also positive. And standard is negative, the delta NRPH is also negative. So both are directly correlated. So standard base excess is more negative in metabolic acidosis and more positive in metabolic alkalosis. So I found a new parameter, delta NRPH. This is also more negative for metabolic acidosis and more positive for metabolic alkalosis. And respiratory component, PCO2 already we know, it is increase in respiratory acidosis and decrease in PCO2. And this delta RPS, this is more negative for respiratory acidosis and more positive for respiratory alkalosis. So using this idea, I have developed a novel ABG interpretation method. So delta pH is equal to delta RPH plus delta NRPH, and delta RPH is more negative for respiratory acidosis and more positive for respiratory alkalosis. Similarly, delta NRPH is more negative for metabolic acidosis and more positive for metabolic alkalosis. So both the components are negative for acidosis and positive for alkalosis. So I've shown some examples. You can see that the pH 7.37, and this is the total change in pH minus 7.4. And this is I have calculated using this previous formulas, delta RPH, delta NRPH. So if you see this delta pH is due to both the changes. If you add these two, you'll be getting this. Similarly, the pH is 7.12. The pH change is minus 0.28. So this is due to changes in both. So the advantage is in the normal method, it's very difficult to tell the contribution of each parameter, the contribution of respiratory and non-respiratory to changes in pH. But this directly correlates. It's very easier to observe. So in this novel method, first you have to identify the component that directly correlates the delta pH. We have to check first you have to check the sign, whether it is positive or negative sign, which directly correlates. And suppose if both the components, already told you, both the components are negative for acidic effect and both the components are positive for alkaline effect. And this delta pH is compared to the individual values. And this denotes the first primary acid-base disorders. And the changes in the other component, it may be due to secondary to compensations, or it may be a second primary acid-base disorder. So only a few examples I will discuss. So here the pH is 7.24. You can see that the total change in pH. pH minus 7.4. So minus 0.16. Now you look at the sign which is having negative sign, whether it's delta RPH or delta NRPH. So delta NRPH is having negative sign. So directly correlates. So metabolic acidosis here. And the change is either due to compensations or second. Similarly, for one more example, I'll show you for metabolic alkalosis, the pH is 7.48. Total change is 0.08. So positive sign, look at the positive sign. This is having positive sign. So metabolic alkalosis. One more example for respiratory, pH is 7.17. The total change in pH is minus 0.23. If you have to look at the negative sign, both are having negative sign, but this is contributing more, minus 0.2. So respiratory acidosis. And here the pH is 7.47. The total change is 0.07, positive sign. Look at the sign. So this is having positive sign. So respiratory alkalosis. And this change other components due to either due to compensations or second primary. So this method appears looks much easier compared to the routine methods, because the previous methods we have to look at each and every values and then we have to correlate. But this here, it directly correlates the total change in pH. Also the contribution of the respiratory and non-respiratory change in pH is also we can clearly see. And one more thing, we have developed a newer ratios. And here the ratio 1 is taken in the ratio 1 is taken in the y-axis, and the PCO2 is taken in the x-axis. Ratio 1 is nothing but bicarbonate divided by standard bicarbonate. So standard bicarbonate is a bicarbonate constant, PCO2 of 40. So as the PCO2 increases, this ratio will increases. the ratio value is 1 at PCO2 40, but as the ratio increases, as the PCO2 increases, the ratio 1 also increases. As the PCO2 decreases, the ratio 1 also decreases. And one more ratio 2, ratio 2 is bicarbonate minus standard bicarbonate divided by carbonic acid. Here in the x-axis, PCO2 is taken, y-axis ratios 2 is taken. And this ratio is greater positive for increased PCO2 and greater negative for decreased PCO2. And the value is 0 at 40 because bicarbonate and standard bicarbonate both are equal at PCO2 40. And one more ratio, modified ratio 2. You just modified the ratio to I have taken 1.2 in the place of, so standard bicarbonate divided by 1.2 minus bicarbonate divided by carbonic acid. So advantage of this using this modified ratio 2 is it clearly demarcates the different PCO2. So using this concept, I have developed a newer graphical tool for ABG interpretation. So in the x-axis, already only few graphical tools available that also not frequently used in clinical practice because of some practical difficulties and inaccuracies. I have proposed a newer model. In the x-axis, I have taken standard base excess, and in the y-axis, either we can take PCO2 minus 40 or the ratios, newer ratios I have found. So in the standard base excess, if the value is more than 2, it can denote a metabolic alkalosis. So it is positive towards the positive side of x-axis, and the value is minus 2. Then the negative side of x-axis, it can denote a metabolic acidosis, and PCO2 minus 40 to minus 40 have taken. So if it is the PCO2 value is more than 45, it can denote respiratory acidosis, and PCO2 less than 35, it can denote respiratory alkalosis. So we can using this graph, we can plot, and then suppose the point is in between. It is towards the x-axis, positive side, metabolic alkalosis. Towards the negative side, metabolic acidosis. And the y-axis towards the positive side, respiratory acidosis. And towards the negative side, respiratory alkalosis. And the point is in between, it can either denote a compensation or a mixed. But how to identify is using the already existing 6 bicarbonate rules. If you apply these compensation rules, if you apply these rules, then the difference between the PCO2 and the expected PCO2 or the bicarbonate minus expected bicarbonate, they will be giving some positive or negative. In the PCO2, we'll go to the previous one. So after applying the compensation rules, if the plotted point is there a shift, upward positive shift, then it can denote a respiratory acidosis. If it is a downward negative shift, it can denote a respiratory alkalosis shift. Similarly, in the x-axis, if there is a right positive shift, it can denote metabolic alkalosis, and left negative shift, it can denote a metabolic acidosis. And there is no shift or within certain limits, only the shift is within certain limits, it denotes only compensations and no second acid-base disorder. So this graphical tool appears much simpler and easier because it's just a simple 4-quadrant graph, and even I have formatted an idea to apply the compensation rules also. And then after the compensation, we can differentiate whether it is due to compensations or it is a second primary acid-base disturbances. So similarly, I can form a graph. Either you can using standard base axis in the x-axis or using modified ratio 2 or a PCO2 minus 40. Or we can merge these two graphs using graphical tools. And one more equation I have derived. And according to the Stewart's acid-base balance theory, bicarbonate is just a marker and does not identify the causative mechanism of the metabolic acid-base disturbances. And usually he has proposed the strong ion differences, and then this ATOD, this is a concentration of dissociated weak acids, mainly albumin phosphate. And these two are mainly responsible for the metabolic acid-base disturbances. And then I have combined everything. I have derived this relationship. The strong ion difference, apparent strong ion difference minus ATOT plus strong ion gap is equal to 960 divided by NRH plus into bicarbonate divided by standard bicarbonate. This 960 divided by NRH plus I showed in the previous graph how you derive the standard bicarbonate, and this is the ratio 1. And using this, I also developed the delta gap is equal to strong ion difference, the main strong ion difference minus 36, or the sodium and chloride. These two are the major strong ions. So sodium minus chloride minus 36. So this delta gap is, from this relation, we can identify the delta gap is proportional to the main strong ion differences. and then delta gap is proportional to mean stronger difference, and this is inversely related to the NRH plus. Similarly, delta gap is proportional to the strong main stronger difference, but it's directly related to the ratio 1, and which is directly proportional to the PCO2. So we can actually, for practical events, we can the main strong differences and the weak acid aluminum can be compared and correlated with the bicarbonate concentrations. So already we know the normal value of a delta bicarbonate from -6 to +6. It denotes high anion metabolic acidosis. If the value is more than +6, either it can denote metabolic alkalosis or respiratory acidosis. I told you previous relations I showed you. Increased strong difference seen in result in lower non-respiratory hydrogen concentration. And similarly, the increased strong difference is also seen in increased ratio. Similarly, delta gap is less than -6. It can denote non-anionic metabolic acidosis because the decreased SA2 will result in higher non-respiratory hydrogen concentration, and decreased SAD is also seen in decreased ratio. This can lead to respiratory alkalosis. So a few examples I have shown for correlating. So major transition paradigm shift in ABG interpretation stepwise. So step 0, we can verify the consistency of the report, and step 1, check the pH and the total change in pH, and step 2, compare and correlate with the respiratory and non-respiratory change in pH. Delta pH is equal to delta NRPH plus delta RPH. And then step 3, we can locate the various acid pHs on 4-quadrant graph. And then after applying the compensation rules, we can identify whether it is due to mixer or secondary to compensatory mechanisms. And then step 5, we can calculate the anion gap, and then just be corrected for the albumin, changes in the albumin concentration. And step 6, delta gap and correlation of the Stewart acid parameters using the newer equation. And finally, the final interpretation can be made with the proper patient history and clinical correlation. So conclusion, ABG interpretation is indispensable, and this method will be especially very useful for junior staffs and junior doctors and staff nurses because they are not competent and it remains an arduous task. So this novel ABG interpretation using the pH changes and the graphical tool and the methods to identify the hidden acid-base systems can easily implemented also because directly it can be, we can develop a mobile app or we can upgrade the software in the ABG Analyzer itself. So implementation of this approach will help to overcome the arduous task, resulting in saving countless lives of patients. And these are my references. And thank you for your patience.
Thank you, Dr. Rajini.
So any questions?